All right, we're going to go ahead and get started. I want to thank everybody for coming to our session today and skipping the residency fair, at least for the time being. So just a little bit about who we are. Moira Davenport, I'm the APD at Allegheny General in Pittsburgh.
And Kevin, I am a third-year resident at Presbyterian Queens.
Christine Stehman, Director of Wellness Education at UECOM, Peoria.
Alvarez, Director of Wellbeing at Stanford, and also the Wellbeing Chair this year. Wellness Chair.
Okay. So now that we've introduced ourselves, just want to say we have no financial disclosures. So get that official housekeeping out of the way. So we have a few objectives for today. The first thing we want to do is help you understand exactly what peer support is and why it's important in emergency medicine. We're going to discuss various peer support models that exist and talk about their benefits and barriers that may come across while using these programs. And then lastly, we're going to talk a little bit about developing a plan to establish formal and informal peer support programs at your institutions and ways to overcome barriers to establish these programs. Or if you're somebody who's lucky enough to already have a peer support program, ways that we can possibly help you improve it. So a lot of the material in our lecture is based on the study that the RAM Foundation did. They did a series of extensive interviews and a really comprehensive and scoping review about different support programs that are out there to help military medical healthcare personnel, I should say. A lot of this talk is based from that and then modified with some of our experiences running peer support programs at our own institutions. So this QR code is up here. I want to give you a moment to take advantage of this QR code and just let us know about any kind of peer support programs you have at your institution, what you might think is special about that program, what makes it work, and what made it easy or not easy to implement, and we can talk about those as we go further through the lecture. Okay, so when you saw this didactic listed in the program catalog, you probably thought peer support. So what exactly do you think of when you hear the terms peer support, particularly in relation to emergency medicine?
Emergency medicine is a really team-based sport, and I think I got my voice loud. Emergency medicine is a really team-based sport. I think we all agree with that, and I think that it lends itself really well to this peer support idea because it's something that we do on shift, and certainly something that we probably do a better job of off shift, but that is necessary.
Any other thoughts on what peer support is and what it means to emergency medicine? Don't be shy. Yeah, okay.
Does everybody have any peer support program at your institution? Yes?
I know. Say, wait a minute. Yeah. I say, you're in the spotlight here. It's
It's a little hot over here.
I know. Okay. So peer support is also known as peer-to-peer support, and it's an organized strategy for giving and receiving some kind of help and support during times of shared crisis and shared difficulties. So there are different types of peer support programs and different types of models out there. Some are very formal, and this can involve something with a set training program, a set location, a set of almost standard protocols that you use while dealing with certain issues that may come up in the emergency department, versus something that's more informal that you can adjust to the situation and kind of adjust to the person and your institution and what resources you have available. So we're going to talk a little bit about both.
So when you hear the word peer, when we talk about peer support, what's the most important word in that? Here, right? Think about it. To truly have peer support, you have to have someone who you consider a peer to get that information from. So before we get in, I'm a bit of a history nut, so history nerd. So I went down a rabbit hole. There is some evidence that peer support started about 200, 300 years ago in France, but the real start of it seems to come in the last 100 years as survival of the mental health system found each other. because especially in the 1970s when a lot of state-run mental health institutions closed, they kicked these residents out and they had no place in society. They were considered dangerous or weird or anything like that. So they started to find each other, and that shared experience allowed them to find peer support and actually survive and thrive in the outside of this formal system. After it found traction in the realm of mental health, it got traction in chronic disease groups and motherhood groups, and it's become quite popular in many circles. I mean, think about the Facebook groups that you're part of. What is that but a peer support group, right? I don't want to hear about finances from a guy. I don't want to be mansplained about what I should be doing with my money because it's very different for women. So my women personal finance group, my emergency docs group, whichever one you're on, my female physicians group, right? It's all a variation on peer support. And why was this alternative when it comes to the medical system so successful? It was because it was based on non-judgmental dialogue, shared lived experiences, and linking to resources, as well as empathetic sharing. Because it's very different when you have that, at the time, the patriarchal level of, I'm the authority and you're the person who's receiving help, and you have to take everything I say, rather than a shared dialogue that says, hey, this is what worked for me, maybe it would work for you, or I found some help here and you could look there too. And so what about in physicians? So in some ways, peer-to-peer support in physicians actually started before the mental health peer support. In the 1950s, there was a set of groups called the Ballant groups. These were aimed to reduce provider distress and improve patient outcomes, specifically in relation to particular clinical cases. So they set out to unpack the interrelationships between patient physical and mental health needs, as well as the physician skills and emotional reactions. So basically you had difficult cases and the patients could be challenging, and how did you deal with them and how were your reactions? And it's commonly used in academic settings and teaching and learning environments based on professionals providing support for each other. Much of that research has been done in relation to educational goal achievement. The combination of professionals providing support for each other in educational settings combined with the success of the mental health peer support groups gives us the rationale for physician-efficient mental health support. I mean, after all, if somebody isn't a physician, or maybe even a physician in emergency medicine in the case of all of us in this room, are they really going to understand all of the problems that you as a physician or an EM physician deal with? I mean, how many of your 9-to-5 dermatologists are going to appreciate what it's like to work 11 to 7 overnight with 30 people in the waiting room? They're not, right? And are you really going to listen to someone who doesn't understand to tell you how you should deal with your problems? You're not. So that's great, but why do we care? Why do we care? Why should I look for peer support? You're a total loner, you don't want to interact with anybody, you're just going to do your job, go home, and not talk to anybody, and you're going to do great? I don't know about you, but I think being a physician is kind of hard. And I'd like the help. I'd like the support. There's a lot of data on loneliness and how it affects us. And so this is another form of connection, right? So over the last few years, EM has become an increasingly challenging profession, as seen by the levels of burnout, the people leaving emergency medicine, whether it's to leave clinical or those who die by suicide. There's much need for physician support and ongoing healing. And then the COVID pandemic exacerbated that by isolating EM physicians and then having associated loneliness, like I mentioned. And it's taken the toll on trainees as well as attending physicians across the board. While many organizations have tried to break the barriers to seeking help for mental health issues, there's still that stigma that asking for help, especially from those outside of EM, is considered a weakness. So you know what peer support is, and why we need it, and where it came from. So we're going to talk through some support programs themselves, including you guys' responses, what those programs might lead to, what you might get out of any various programs, and who can participate. And then we'll talk about some examples and actually some barriers and how you might overcome them.
All right. So that's the question is pointed out there. Like, what might you get out of peer support? Why do we do it? Oh, I hear some mumbling. Yeah?
I mean, I guess I'm trying to decide if it means what I might get out of it or what we might get out of
Safe
it.
space, whatever.
I mean, I think, it's, not everyone, for instance, in my group wants to go see a therapist.
Yeah.
But probably everyone in my group needs to periodically talk to someone about kind of what they're experiencing. And so knowing that you have someone who can do that kind of reliably, safely, and get kind of an ear that knows how to listen, would feel really good sometimes with that.
I like that a lot because what you're highlighting is that we chose a hard path, right? We chose medicine, and it's not supposed to be easy. And yet, there's this idea that we're supposed to just get through with it and just do it and deal with all the crap that we deal with. And the reality is that it doesn't have to be. You don't have to go through this alone. And so is there a way for us to get some sort of support, be it from a peer, a colleague, or formal ways, which we're going to go over, right? It may be therapy. It may be a coach. It may be a peer-to-peer support. But whatever that is, I think what you're highlighting is this need for us to also be seen and to recognize that what we're dealing with, they're not easy, and we chose the hard path, right? This was not supposed to be easy. So for the residents in the room, nobody said that, like, come join us in this residency program. It's the easiest residency program. We don't say that. And if we do, then we lied to you. Right? And so because of that, we have to also acknowledge that you don't have, again, to go through this alone. So here are some ways that we can think about it, right? It can enhance physician well-being, whether it's at work or at home, because the reality is we take this home as well. It can also actually just improve the working environment. When we know that printer is not working, and every time I print this prescription, things do not work, that is so frustrating. And maybe to the 10th person that I say this, they're not going to be able to fix it, but there's a sense of reassurance that I am not alone with dealing with this crappy printer that does not print the prescription that I needed to print, right? And maybe eventually it'll get trickled into the right people. But being seen, being validated for the experiences that you have, I picked the printer, but there are many more realities that we deal with, like dealing with a trauma, making decisions like I have to discharge this patient because the emergency department is full and the medicine service is full and there's no other place for this patient. Making those compromising decisions, they're not fun. They erode in our sense of like, this is not what I signed up to be, and yet we chose the hard path, right? And the third part is really why we care about it also. We need to take care of each other in order for you to be there for our patients later on. Right? The reality of 550 spots being open kind of like shocked us. But really, is it really a shocker? We chose a hard path. Our specialty is hard. And there are ways for us to protect each other. There are ways for us to take care of each other. Now we're going to do it. I love it. See?
Okay, thanks. I'm just going now. Because it's not really fair to take home to our families.
That's right.
We did choose a hard path. It's not really fair to me to hold on to it all by myself, because then it just builds up.
It's okay. Continue, please.
But it's also not really fair for me to kind of go and dump it on these poor unsuspecting family members who love me but don't really understand what I'm doing. And nor should they, right? Kind of like the dermatologist doesn't understand what I do, neither should my family members really.
That's right.
And so it's just not really fair for them to be the sole place where I dump all of that.
I like that a lot. It's not fair for our family members, for our friends who are not in the emergency department to get dumped on with the emotional toll that we just experienced. And yet, these are emotional tolls that we just experienced.
And it's also not fair for you to not have anybody other than your family.
That's right. It's not fair for me to dump on somebody who's clueless about what I just went through, right? And they look at my schedule. I'm a nocturnist. And so if I say something, I'm like, oh my gosh, like, that was really rough. And they're like, yeah, it must be really rough. I can work overnight. I was like, you just like invalidated all the things that I said about like the patient dying and the crash, and like you're focused on me working overnight. Because they don't see that. Or I think there's the added effects of not to explain what a central line is, that I caused a pneumothorax, that this happened, right? Being able to talk to somebody who understands what it feels like to be in that situation is less exhausting. Great. What else?
I also think your first point was really important as well, because one size does not fit all, and one size might not even fit you for every experience that you have that you want to talk to somebody about or to cope with. So I think it's really important to keep in mind that one size does not fit all, and what works for me in the past might not work in this situation.
I love that multimodal way of getting support, right? Your friend, your best friend, your buddy, your significant other, they may provide you a certain level of support, but there are certain needs that we have, right? As emergency physicians, that's why we have EM docs. That's why we have all these affinity groups, to be seen and not have to explain ourselves over and over again. There's also other things like malpractice, like people who get sued, like you're not allowed to talk to people apparently, right? How cruel is that for the emergency physician who was asked to see patients in the waiting room and then have to discharge the patient, and then something bad happens, and then all of a sudden they're expected to just navigate the patient complaint, or worse, a litigation, right? Peer support can offer that solution as well.
I think that really highlights the importance of having people at various points in your training, because as residents, we don't experience the litigious side of emergency medicine, but we're deep in the trenches of having that balance between feeling like we know what we're doing, but also having this huge knowledge gap.
Yeah.
The attendings may not feel anymore, and so even just having somebody in your own class or within your own program, or similar training levels of training, is incredibly important.
I like that. So even within the confines of amongst emergency physician, maybe I just need to talk to my colleague who has gone through this, the same level as I am, or maybe there are some parts of it that I need to talk to a senior, and maybe some parts of it for a junior person, right? So a resident, talking to a resident versus worrying, talking to a faculty who might then get them in trouble. Kind of, we got over this, right? So what might physicians receiving peer support expect as a result? Right? Simple things. You want to be heard. You want to get that support. Also, maybe there's a sense of education. Can we get some learning opportunities here that will get us there? Am I not moving at all? Oh, are you rushing me? Okay. Oh, that's okay. I got it. Thank you for the support. And also, given resources, right? Referrals, because maybe I don't need to have all the answers. So I think that takes away that, so I'm one of the peer supporters at Stanford. And I can honestly tell you, in my 7 years of being a peer supporter, we get less than 5 people reaching out to us for support per month. How odd that is, that just emergency physicians in a given shift, how many times do we deal with all the crap and trauma and vicarious things, and somehow we just figure it out. We just go home and talk to our friends, our dog, or whoever, and maybe get some validation, right? And I'm not talking about even cases that lead to M&M, things that led to litigation. And our peer support is protected. California 1157 protected. They can talk to me about any detail that they want. Most of the time, in all of my years of doing this, most of the time, people don't even talk about the case. Because I just ask, how are you doing? Because I can imagine it feels really crappy to go back to the emergency department knowing that you're going to see that room again, right? So who can provide support? I think there's several areas here, right? There's the profession, we talked about this amongst ourselves, physician to physicians. Physicians are not comfortable talking to non-physicians about certain things that we deal with. There's also the level of experience, as you highlighted. It may be, if you're a resident, you want to talk to a resident. If you're a senior faculty, you may feel intimidated talking to a junior faculty about things. So having a diverse group of people that you can talk to is important. Is it within just a hospital setting? Is it maybe just within medicine? So this is from the RAND report. So they talk about occupational setting because the military was involved there also, law enforcement. So then what now, right? How do you then get people to be peer supporters? How do you choose them? Do they need training? I have to consider this now because, again, when I started being a peer supporter, I went through training. But if I'm only getting less than 1 for several months, there's not going to be like enough training that I go through. Like, this is a process. I need to learn how to talk to people when they're in distress. So I don't like put in like the experience that I went through that. This is what I did. Well, I just invalidated the person. Or like, oh my, that must be really, really frustrating. Oh, let me do this. Like, what if you do this, right? So giving them solutions, that's also disempowering. So there are ways of providing support that actually encourages people to feel empowered.
So as far as like the roles like in participating in peer support, there are certain requirements and responsibilities that like we ultimately will need some sort of training in. Whether these are informal, these are things that were taught to us. It depends on whether or not we have an official program that'll help provide the skills to do all of these jobs, whether it's like the coaching we're going to get, counseling, or being a good mentor, whether it's having a peer supporter to help facilitate someone going through a tough time or moving up in their career, or moving ahead into their career. As we said earlier, we had the different varieties of our formal as well as informal peer support systems. Our formal ones, as Ali had said, like you had to go through a specific sort of training system. At our shop, we only just recently started like a formal peer support training program that was kind of instituted by our GME. But it started at the beginning of the academic year in July, where we recruited people from the residencies to have resident peer supporters for each other. And from what I understand, there's like formal classes or training like time that is set aside to participate in this. But we haven't, so it's only been like the first year that it was implemented, so we haven't really had too much results from it yet. Regardless, there's usually some sort of expectation for how long people are participating in these peer support in sessions with each other, as well as like expectations for what outcomes we're going to get from being in these sessions. And at the end of the year, they try to measure to see, like, is this an effective intervention for our residents? The informal ones we kind of almost always had, and that's just because of the very social nature of our profession, our training especially. So let's see, these ones, yes, okay. So depending on where you are, you may or may not have all of the examples that we're going to go over. You might have some of them, and it's okay if you don't have all of them. You have to figure out which is going to be the best fit for your situation. I can go without continuing unless we talked about Indiana universities. Like during the height of COVID, I'm sure you always remember like New York. We had physicians leaving their families, staying in hotels, isolating from their friends, their peers, only going to work. And in that time where we're extremely isolated, our well-being was very much at an all-time low. So what Indiana University did was they created a virtual group-based peer support. These were led by EM physicians there, and it involved about 24 EM physicians to participate in this peer support, these peer support groups. And overall, it showed that it was very easy to implement, had a very positive effect on all of the participants. And all the participants thought that this intervention was very well received. And I think as a follow-up to this peer support structure that they created, they started a peer support group for malpractice as well, which they've also been implementing as, I forgot, since last?
Yeah, so they actually presented it last year at SAEM as a poster, and they've presented nationally. They presented to the entire University of California system, and they're really taking this. And I think this was all EM, but the malpractice was just through, it was all specialties. And they set it up so that people had someone to talk to. And I think they got it protected through almost like a peer review process, so you can share if you need to, which is huge when it comes to malpractice cases.
So I'm a resident, so obviously I can't get away with talking about how our most important informal peer support system is ourselves, our class cohorts that we all start off with. In addition to this, what I have seen at our shop is we had this combination of what we call as like a big and little sib sort of program, where our third years are paired with a new intern, and our chiefs go through the process of pairing them based off of what they like and their similarities. And so the first month for our interns, they all have this orientation month where they have shifts that are in the ED where they're not really obligated to see and move patients. They're there to really follow their big sib around and kind of get an idea of how their big sib works and how to get used to the system. Throughout the year, they're also what I try to do with at least my little sib is to hang out and touch base with them to see how they're getting along with the stresses of being an intern, going from a med student to having the new responsibilities of being a new doctor, and how having them see how they're holding up to the graduated responsibilities of becoming now an intern to almost a new senior now. What else do we do? And then we can also have our peer support systems through each other and as well as through our mentors. Through our mentors, what we have done is that we have our interns, they get to work with all the different attendings and they actually get to choose their mentors. Some of the mentors will get to have I've heard this family line concept where they have the mentor and then one resident from each of the different years, and that's the family line where we'll all have family dinner, go out and get sushi together. That's all what Sushi on Me is the most recent one I heard about.
That's actually what that picture is.
Ooh.
Yeah, that's my family group.
And then, yeah.
I'm hidden by the dogs.
Oh. I was wait. Okay. And then one thing that I saw very quickly happen at this year was our very new physician cohort, because we have a lot of residents that became new attendings, new fellows at our shop, and then almost very quickly they all formed their own group, started hanging out very closely. And I think this is very important to highlight on the new challenges of becoming a new physician, having the responsibility of signing all the notes at once, having to deal with a very full inbox of patients that you have to click sign and hope your scribe had finished all the notes correctly and typed everything correctly. Now, as far as all of these are very informal ones, so they don't really require a lot of training, but certainly could have an opportunity to get additional training as how to be a good mentor. There are plenty of books out there. I think what impacted me the most actually was talked by Dr. Arlene Chung regarding how to be a mentor and how to set expectations for what mentorship should really be like. Now, as far as the formal ones we talked about, right? These can be implemented by GME, or they can also be implemented by your hospital. Some of these will have official peer support training courses, and these are ones that will offer on the job, to address on-the-job trauma or debriefing that is not really necessarily treated or addressed right after critical cases. So yeah, hospital-wide, same thing, but basically it can be implemented as far as an enterprise-based support.
All right. So I have some of the answers that people answered in the initial survey. Surprisingly, many of you are not sure if you even have peer support. So maybe I'll step back here a little bit. I'm ad-libbing here a little bit. How many of you here are residents? Great, a lot. Yay, thank you for joining us. How many of you here are first-year residents? Thank you. Second-year residents? Third-year residents? Great. Fourth-year residents? The reason I'm asking this is that congratulations, you're about to level up to be a second year. But I'm not sure if you know this, but there's data that shows that the first 3 months of intern year is the highest risk for residents to have suicidal thoughts. So imagine that, right? Several of our colleagues go through this, knowing that they're feeling lost, and nobody seems to know, do we even have peer support? So something is happening that somehow we're not really connecting with their support here. There's infrastructures for many of you. You just don't know that it exists. Or there's infrastructures that you didn't even know you can access, right? And so maybe, I'm going to pass this back. Because I think we made the points that not everybody here knows that there's actually peer support. So let's talk about the barriers. Like, why is there a barrier for maybe getting peer support? I think that's easy, right? Like, there's no intentionality, there's no funding, right? A lot of these work, as a peer supporter, I'm volunteering my time. And so how does that mean, like, what does that mean for other people? Like, they're busy, they're also expected to perform education, research, all of these things in order to advance. And yet you want people to volunteer. There's also real, I mean, I asked for funding for peer supporters at our shop. And then there's that answer of, well, if you're only getting like 1 or 2 or 3 every year, do we give you a ton of money to do that, to be on call as a peer supporter? Or do we use that money to reach trainees, to reach faculty at a different level? These are real questions. So I'm asking you as the audience, like, what are the barriers that you anticipate or you experience or you've seen that's preventing us from even having peer support or even using the peer support programs that we have in our institutions?
I think one of the barriers is that it can look different for a lot of different people, and so, you know, at our institution, we have like advisors and
Yeah.
attorneys, and that can look very different depending on what your advisor values or what they determine as like what that relationship should look like.
Sure.
So you have some that are very involved and check in on you every, couple of weeks and are actively pursuing you, and then there's others that's like as needed, if I'm not, you may not feel comfortable to kind of break that barrier, reaching out to them.
Got it. So it may mean that some people may get that peer support that they need. We just don't call it peer support because it comes in a form of mentorship. It comes in a form of maybe advisors or just near peer that they can talk to. And so that's why they're not utilizing the peer support program. It may mean also that there's just variations of practice. Some people are getting the right peer support through the right channels of mentorship, advisors, and sadly, there's going to be people in our program that, for whatever reason, either their faculty or their mentor is busy, not trained, checked out, right? They're not getting the right support. That's a very good point.
I think there are kind of a lot of barriers now that I'm sort of like thinking about the question. Like, I know we set some things up, especially early in COVID, and no one took advantage.
Yeah.
So that's one thing, and so those sort of fall away if
Yeah.
no one actually takes advantage of them. I also know that we started doing like Schwartz rounds,
Mhm.
which was like a hospital-wide thing.
Can you explain it for people who may not be familiar with Schwartz rounds?
Yeah, so it's maybe in some ways kind of like ballot groups. There's
Yeah.
an organization through the Schwartz Center for Compassionate Care, I think out of Boston, if I'm not mistaken, and you join the Schwartz Center, and then you become a member institution, and you get trained about how to hold Schwartz rounds. And Schwartz rounds are multidisciplinary rounds. They're not just for physicians. They can be for
Yeah.
nurses and pharmacists and respiratory therapists and anyone in your entire institution to talk about either a particular case, maybe that was a difficult case that had a lot of emotions involved, or to talk about an issue like the first patient I had who died.
Yeah.
Or my best moment in healthcare, or like, so they can be positive or negative, case-based or not. And the idea is that they can be open to the entire institution, and so you can have between 20 and a couple hundred people maybe come to a Schwartz round that sort of all participate in this group peer support conversation, I guess I would say. And we tried to implement our sort of own in-house version of that because our hospital wouldn't support us paying to join Schwartz
Yeah.
because it's expensive. And that also kind of fell apart in a hospital merger, so there wasn't necessarily institutional support for it. So I list that kind of as another barrier. And then I think the other one is I would call cultural. So you can set up something, but if the culture of the institution doesn't really support that,
Reaching out, yeah.
or it's not the kind of place where people even feel comfortable maybe talking.
Yeah,
one-on-one,
stigmatized.
it's much more of the informal than
That's
the
right.
formal peer support. So, and I think there are more, but those are the three I'll kind of mention right now. I just think sometimes you can set something up and it doesn't always work.
I like that a lot, because even though there's good intentions of setting something, if people are not using it, and then there's a perception that, well, maybe people don't need it, right? It's just, that's not,
Or we're not going to spend our money on it because we have other priorities.
that's right. There's other competing priorities that people may use, so that's important. I really also like the intentionality there that you use, like, it could be positive things. So how many, I've used this in other talks, so if you've been in some of the talks that I've been in, like, I thank you for being here again. But how many of you have had those, like, great intubations? Like, that was a difficult airway, and you're like, got it. Yes? No, don't be shy. Like, you totally own it, right? You just did this. I'm making a point here, right? How many of you, what do you do after that? You just had a great resuscitation. You intubated this very difficult airway. What happens next?
I guess you want to brag to people.
You brag to people, but what does that mean?
Human nature is
Yeah.
to, want to spread the word and, tell as many people as you can.
Great.
Use it as a teaching opportunity.
Sure.
You know?
How often do we actually do that? Those sound great, but how often do we do that? Because oftentimes what I see, even residents do, is like, oh wow, that was a really great resuscitation, that was great intubation. They high five and then they leave and then they just move on and do other things. How often do we do that? Very, very common, right? What would it feel like to have an attending or a peer come up to you and say like, hey, I know there's like a ton of patients in the waiting room. I know we got to see more patients and we got to do more things. But I just want you to pause and recognize that this patient is alive because of you. Right? And I get that goosebumps moment. I don't know if you felt that, right? And so I call that like these goosebumps moments. And I say, what you're feeling, this is what it feels like to save a life. We don't pause to acknowledge all the great things that we do also because it's just expected of us, right? But that stupid printer that is not working, we are so quick to like focus on that because it is a crappy thing that we deal with. My point here, I love that, Dr. Hirsch, right? Like, we can be intentional with peer support to actually celebrate things. Mentors, right? Like celebrating the wins and not just like thinking of mentorship as like, oh no, they have a problem and I'm assigned to be their mentor. It could also just be celebrations on the many things that we do amazingly in our work. Because we chose a hard path, and there's a lot of great things that we get to do in emergency medicine, right? Peer support allows us to really just help each other, even if that means just being acknowledged for that cool thing that we did.
So I think after all of this, you understand that you need some form of peer support at your institution, whether it's formal or informal, but you're probably feeling a little overwhelmed. You're like, hey, you can do all these different things. And you probably know your institution is not going to give you any money because that's probably the biggest barrier that everybody deals with when it comes to starting a peer support. If you're not really sure where to get started, we actually took the RAND group framework and modified it for emergency medicine, and basically a series of questions like that you can go through and answer for yourself so you can figure out some ideas on when you're starting a program. There's also a list of references in this handout, both from this talk and that might serve as an additional support for you on this journey. So please, I'm going to leave this here and ask if anybody has any questions while you take a look at the handout. So,
can I give you some tip that I did not know actually is a thing? I know people are like doing the QR code and you click the link and then invariably that gets lost because there's probably like 50 other like links that open because we're at SAEM. I did not know you could just take a picture because it stays on your camera. You can double click on it later on and it still opens the link. So take a picture instead of just clicking the link so that you remember where we are and that way you can have it.
and you can also download the slides. And you can send them to your computer if you want to, and then you can do the same thing with the QR code that way. So,
before we go to questions, I just want to pause here and also just acknowledge the team who really put a lot of work here, especially Dr. Stehman, who really did almost all of the work here. And so I just have to say that out loud because again, this is what it feels like to do something great here. And she's done most of the work here, so thank you. questions, comments, reflections, pushbacks?
Say you're gonna take the 10 minutes left over and be like, peace, I'm done. That works too.
That works too. Yay, leveling up to a second year.
So I'm in a program that has some of those kind of structures in place. We have kind of a big little sibling program. We have a mentorship program, it's maybe a little bit more formal. But we have similar experiences, you know, everyone gets a different experience based on who their mentor is. And we're looking, our program director is looking to launch a more formal or more kind of like novel program, willing to dedicate some resources, question mark on that. I think one of the big challenges that we've had is that we haven't had a lot of response or a lot of involvement in some of the other, you know, more classic forms of peer support, both at the big little, the little big sibling program. A lot of groups just don't get together very much, and I'm really interested in hearing from others too. What are ways of getting people engaged in this a little bit more? Maybe hearing novel structures. Is it involving, you know, you kind of put some of that up there, you know, maybe hospital-wide, or how can we sort of spark the flame of, I think some of our structures that we have in place have just gotten a little stale, and I'm curious of any more like innovations and how we can get people excited about.
So I would say the first thing you do, Dr. Hirsch introduced me to the idea of participatory research a couple hours ago, and basically you ask the people that you want to help what they want. So I call it a needs assessment. I do it every year with my residents for the wellness curriculum. What do you want? What am I doing? What did I screw up this year? But ask your residents. If you want your faculty involved, ask your faculty, what can you give me? Who wants to participate? Because you don't want to do another voluntold fun, right? That's not fun. That mandatory fun is not fun. The bowling was fun. But ask them, because maybe their response is, I just want you to leave me alone. And half your class might be there, but other half, you know, if you have 2 faculty that are willing to put some time in, and a third of your residents want something, maybe you formalize that group, and then you see how it goes, and they spread the word, and the next year you make it bigger because you have 2 more faculty and maybe 5 more residents that want to participate. But don't put people aren't going to participate if they don't want to, so make it what they want.
One of the things that, so I'm at a place where we're currently at a status quo regarding unionization, which means that we can't implement new things for our residents, and that's okay, right? But we have to be creative about how do we get funding for fun stuff for the residents. And so for me, I have the design thinking training, and so I love problems because I see it as constraints, and then we get to be creative of how to look at that problem. And so what I heard from people was that because we cannot implement new things for the residents, because of being in status quo, what I also heard was then that means if I focus on the faculty, I can get funding. And so one of the novel things that we've done, not really novel, is then there's data for commensality groups. So just having dinner together with one topic, not having like a lot of things to talk about, just give them one topic to talk. Maybe it's like your joy in like the last shift, just asking one question. If you do this on a regular basis, even for 6 months, there's significant improvement on their well-being. And so knowing that data, and knowing that I cannot fund residents just to go to dinners for fun, our resident asks, like, what if we have faculty join those dinners? Because then I can pay, I being the department, can pay for those commensality dinners. Again, just being creative to meet the same need, which is we need to create spaces for people to be able to talk about things, to have this peer support. I can go, like, there's many other versions of this, but like, for me, understanding the problem better, the needs assessment, the participatory research is important, because most of the time, as long as you actually truly understand the problem, creative ideas come up. Oftentimes what happens is like we think we know the solution, but we actually didn't even understand the problem. We think we're just overlaying some solutions that we've heard from other spaces. But to be truly innovative, to be truly creative with the solutions, you have to just spend a little bit more time on the problem. So you gave me, you shared a very important problem. There's a lot of layers there, right? So just pick one corner of that and then focus on that part. Because what I heard was there's maybe funding, there's some interest from the leadership. I look for alignment. Funding, leadership support, asking the residents what do they want, and then connect them together, right? And then you present it somewhere else. Because the more you get recognition, there's this social proof that happens. Wow, Beaumont is doing this. We need to do more of this, right? And that also gets you to promotion and like all the things that happens with getting your work, education, and research. Great question. Any other questions?
Well, thank you for your time.
Yeah, the meta-editing said like to pause for 7 seconds, and I did. I will just leave you with this. I hope that each and every one of you realize that we can be peer supporters. And that also means that we can be peer supporters for ourselves, that we also need the help, we can need the support. And that requires an acknowledgement that you're not alone in this experience. We chose a hard path, and we don't have to go through this alone. So thank you very much.